Welcome to Pharmacy Pathways, everybody. I am so excited to have here with me my friend, Dr. Alicia Scott, and she just so happens to be a board certified transplant pharmacist. So, in this episode, she is going to take us on her incredible journey. She's going to give us the inside scoop on what the day to day life is like for a transplant pharmacist. And of course, she's going to share some tips and tricks of best practices. So, I'm excited for us to get into it. Welcome, Dr. Alicia.
Thank you. Happy to be here.
It's really nice to see that you are in solid organ transplant and you are killing it because BCTXP is board certified for transplant. So you're also going to be talking specifically on what the board certification process entails. Before we, hop right into your role, share a little bit about who Dr. Alicia Scott is.
Yes, happy to. Claim Houston, Texas. I grew up here. My family's been here for 20 years, so this is definitely home. I went to undergrad and pharmacy school at the University of North Carolina at Chapel Hill. And then I came back to Houston for training at Baylor St. Luke's Medical Center for PGY1 and PGY2 training. Really am passionate about health literacy, and I found that transplant was a great way to be an advocate for my patients and help empower them in their understanding of their medications and the importance that they play in making sure that the organ and everything continues to work and that they remain healthy for as long as possible. So I've really found my niche, I think.
How did you get exposed to solid organ transplant?
It's a great question. What really piqued my interest was I was at a SNAFA conference one summer, and one of the sessions was listening to a transplant pharmacist speak about his day to day and his responsibilities. And then I was fortunate enough to get both an inpatient and outpatient rotation as a fourth year student, which solidified that this is what I think I see myself doing. Really was able to tailor my electives and my rotations to help make me a strong PGY1 and those things that were going to be important for solid organ transplant pharmacy. And for example, what we like to say is that transplant is internal medicine on steroids. So we are managing immunosuppression, we're managing infection prophylaxis, we're managing uh, endocrinology, cardiovascular if the patients have blood pressure or hypertension that develops as a result of the medications that they're taking. So we really have to be well-rounded. And so I think that internal medicine experience has also helped me develop and become more clinically apt in those areas so that I could translate it to transplant when the time came. As a fourth year student applying for PGY1 residency programs, I was looking at programs that potentially offered early commit opportunities for PGY2 in transplant. So that did help me narrow my search and my focus. And then ultimately, it came down to a fit thing. So a place that I felt comfortable and felt that I would be supported and offered a wide variety of experiences. I think something important to keep in mind if you're pursuing transplant or interested in transplant is that not every transplant center offers every organ. So there may be centers that only do kidney transplant or only do heart transplant. But I think for a training perspective, it was important to me to have experiences in the four major organs: heart, lung, liver, and kidney. And so I was able to get that from my postgraduate training and then spent second year after early committing really delving into those organs. Personally, we had 2 months rotation, so you spent a lot of time with the patients, the preceptors, really getting to learn nuances for each of those subgroups of solid organ transplant. I felt very confident coming out of every rotation that I could take a job in that particular organ if I chose to. But ultimately, I think people always have like an organ preference. For me, it just needed to be below the diaphragm. I definitely preferred abdominal, liver, and kidney as opposed to the cardiothoracic side. So fortunate that job opportunities presented themselves in that area.
The pathway that you just had, that you just shared for you personally, a PGY1 broader year that is most likely going to be inpatient?
Yes, I'm glad you said that. So there are two typical routes I would say that I see people doing: a PGY1 in acute care, which is inpatient, and then you do your transplant acute care residency. So more than likely inpatient and outpatient mix, depending on the program. The other pathway that I've seen pharmacists in my field navigate is that they potentially do an AmCare, either PGY1 or PGY2. And then a lot of times places will have a transplant rotation or they're able to then work in a transplant clinic setting. So those would be the two typical ways. But I would say that almost everyone in this field as a specialized transplant clinical pharmacy specialist, they have completed a PGY2 training. One thing that I feel like is important to note and kind of where we're at and just across the board as organs are becoming more available and more transplants are taking place is that we've kind of expanded our pharmacy model. So we're including like a PGY1 trained pharmacist who is helping with those education sessions we mentioned earlier, which I think is a great way if you maybe choose not to specialize and go through PGY2, you still have an opportunity to work with this patient population and get to be a part of their journey, which I think is fantastic. And we definitely need to utilize everyone to make the best impact for every patient that's being transplanted.
That's very good insight. So it sounds like if you kind of know that you would rather work in a clinic setting, then you can do the AM care first year. I'm curious because I'm a nervous Nelly. If someone decided to do an AM care rotation for the PGY1 and I'm sorry, AM care PGY1 program and then try to specialize in the hospital setting, would that be also appropriate or deemed prepared?
I think it's harder to translate. I feel like if you chose the AmCare route, that's probably a better fit for a transplant job for you, taking a like strictly outpatient. Not to say it can't be done. I have colleagues that took that route and then just because of shifts in staffing, they were pulled inpatient and now they are, you know, just as qualified and capable of covering inpatient and outpatient. I think if you are completing a PGY1 in AmCare, the outpatient role would probably be the best route. Like if that's the only postgraduate training that you completed, outpatient transplant would make the most sense.
Expanding on that, because you are board certified, that's an additional thing that we as clinical pharmacists are doing after residency. So if you could talk a little bit about the board certification process for transplant specifically. It would be nice for you to at least start with like what are the requirements to even sit down for the exam.
So the most common route, similar to what I've said, you've completed a PGY2 in solid organ transplant and that is one of the pathways. The alternate pathway is that you have, I want to say 5 years of experience in the field, but I think the most common route these days is PGY2 training. And then you sit down and you're studying for the test. But that's really the only requirement is that you have experience in the area previously prior to taking that exam.
And what was your reason for getting certified, board certified, being that you went through a PGY2 that specialized in it? What's the incentive?
Different hospitals have different incentives for becoming board certified. For some people, it's a pay increase. That wasn't my personal experience, although I think it would have been nice. But I do think it helps basically your application for promotion and your chances of moving up in opportunities.
Hmm.
And from outside of that perspective, I also think it just helped me really solidify the knowledge that I had learned because as a new clinician, I got licensed or I became certified within my first year practicing. And I think it helps really, for me personally, build my own confidence in the knowledge that I've gained in myself as a resource to my interprofessional colleagues. Being able to pass that exam, right? This is the benchmark for a transplant pharmacist. Then I wanted to be able to say that that's something that I accomplished and am knowledgeable enough about.
And did you see anything on the exam or did you come through any studies, materials that were different or additive to your experience, your training experience?
I would say that is the really unique thing about transplant is that practice is so different everywhere that you go. So it is really hard to standardize and then test on that. Obviously, there's basic pharmacotherapy knowledge that's going to translate across the board, but as it comes to like studies and, what has research said about this particular therapy plan, that is such a small sample size typically, but also varies depending on the center in terms of their practice and their outcomes. So that was something that I leaned heavily on my personal experience, but then I utilized ASHP and ACCP's standardized resources because at least if what I did was so different than what most people in the country were doing, which I doubt it, but you just never know. I wanted to at least be able to have a good understanding of what the consensus is. And so I think that those resources for transplant specifically, just because practice varies so much, that is really important to utilize as you're preparing for the exam.
The take home message is don't expect to see extra dollar signs on your check, but it does make you a very competitive candidate when you're going up against other people who may not be certified, and it is that extra stamp saying that I know my stuff in this area.
Right.
I want to circle the conversation back to the different organ systems. You made the comment that you knew you wanted to do something below the diaphragm. Why did you make that comment?
I think that for me, so abdominal transplant, liver and kidney is typically a lot faster paced. Like most kidney transplant programs discharge patients 3 days post-op. Liver transplant varies depending on how sick they were prior to transplant, but those are still I'll say fast movers in terms of your transplant patients. And I think their course is typically also less complicated. If you think about the heart and the lung, those are necessary organs to function and to breathe and to live. And so obviously all of them are, but there are other ways around managing kidney dysfunction or liver dysfunction that you don't always have with heart and lungs. So all of that to say their courses were a lot more complicated. And I think that you kind of felt like I was losing the light a little bit with some of them. I had some really tough cases as a PGY2, and I think I just felt more joy in what I was doing on abdominal and abdominal transplant because that allowed me to see the good part of it more frequently. And that's not to say there's something wrong with cardiothoracic transplant. If you have a cardiology interest, then that would be a perfect fit. Or if you really like infectious disease, that's huge in lung transplant because they're exposed to environmental pathogens, and that could potentially damage the transplanted organ. So there's definitely a niche for everyone. I think that, but for me, that's kind of how I came to that conclusion.
That's speaking to what you're able to handle as a person.
Definitely.
Some people can work at funerals homes and go to sleep, kiki, and it was a great day for them. And then other people like me, that would just that would really be hard
Yeah.
burden to handle. So are you inferring that perhaps there is a lower success rate of those transplant procedures?
I can't even say lower success rate. I think it's that it's not done as frequently because thinking about kidneys, right? For every donor that we get, you potentially have two kidneys, and that's two people who could get a transplant and change a new life and get off dialysis, that type of thing. Liver, if they needed to, they can cut it in half, same type of thing. I would say more often than not, there's less damage to those organs as opposed to the heart and lungs may go through a lot more stressors throughout a person's life. And then that means that can impact the quality of the graft. So overall, those transplants are done less frequently than the abdominal transplants. And I think because you have a smaller group of patients that have a longer and potentially harder course, that's where I was getting at. It may be more difficult, or at least it was more difficult for me in those cases with less optimal outcomes or a long, difficult course to stay positive and continue to be hopeful in that standpoint. But I think from the more frequent flyers, you get to see the turnover and the change a lot more often. These patients are being transplanted and I'm getting more exposure to their care and the different cases. That I think gave me the more value. But there's also value in getting to know that small subset of patients really well. So
Uh-huh.
like you said, it depends on your own personal personality and how that would translate into your role as a
Yeah.
pharmacist as well.
And correct me if I'm wrong, but I vaguely remember that different organ systems had different expected life expectancies. You probably know liver for sure in your specialty, but do you also know the other organs and what their typical expectancy is after the procedure?
Good question. So I think that also plays into it. Lung, I'll say, is for a long time, they said it was 5 years. I think we're seeing a lot more patients have a longer life after that, which is great. But that would be the shortest life expectancy out of those four main transplant groups. Kidneys can last. Sometimes I have patients with livers and kidneys that are older than me. But on average, I would say kidneys and livers can be somewhere between like 10 to 15 if everything goes according to plan. Heart is also more complicated. I would say it's probably more than the 5 years you see for lung, maybe closer to like 7 or 8.
All right. And pancreas, is there a certain expectancy there?
That one I would say, ooh, that's a good question. I think there are so many complications with pancreas transplant, so it's also not done very frequently. But when they do occur, somewhere between 5 to 10 years, there's lots of potential infectious or digestive complications that come as a result of that organ. And I'll admit that's not something I trained with. I have experience with it in my current job minimally. but that was not an organ that we transplanted where I trained. So I don't feel like I'm an expert on that one.
So are there other considerations when deciding like which organ system you might be best vetted for outside of the emotional lifting that it might have to come into play?
I think there's consistencies across all of them, right? Like I think all of my colleagues are passionate about their patients and the care that they receive. But I feel like you can have really complex or rare cases occur on any of the organs. But I think it really is just going to come down to what your additional interests are. So, for example, I had a preceptor that actually was cardiology trained and then ultimately took a transplant job in heart transplant and mechanical circulatory support. So that even though transplant may not have been his initial goal, he was able to translate that and function effectively in that role. I think for lung transplant pharmacy, like I mentioned, infectious disease is huge. So that they have a very strong knowledge in that extra ancillary piece of solid organ transplant because they'll see a lot of those complicated or difficult to treat infections in their patients. Kidney and abdominal are a lot more holistic management. Okay, let me back up. Specifically, one of our main go-to drugs in post-transplant is called Prograf or tacrolimus. That drug has known side effects of kidney injury, hyperglycemia, hypertension. So all of these different systems are now being impacted, and we're trying to manage that, but also keep the graft alive. And thinking about for kidney transplant, like potentially this drug could be the reason that your patient's kidney fails. So these are all things that we are taking into consideration as we come up with a patient-specific regimen for them. And I guess I don't know if this is a good analogy, but I feel like liver and kidney, it's a lot more juggling. You're just dealing with a lot of different things and more frequently because of the volume of patients increasing. That's another reason why I think it was a good fit for me because I kind of thrive in a multitask type of environment. And so I think being able to do that also would serve someone well as an abdominal transplant pharmacist.
I'm just thinking about all the infections that you probably are seeing with the pulmonary. We have to mute the immune system to some extent, but then they are going to be more prone, not just to general infection, but lung infection. And then their age is going to play a factor. The community that they live in is going to play a factor, all the things.
I hear you. I feel like I get enough of it in my current role, but not so in depth that I wanted to be an infectious disease pharmacist. So transplant gives you a good mix of that too.
Yeah, I can imagine. I never really thought about how much you would have to see and also the endocrinology piece.
Correct.
So you're a pharmacist on the team, and I think that is growing in familiarity. But some people might be wondering, like, where you fit on the team if we have doctors who are specializing, NPs, PAs. Why do they need you as a pharmacist? What are you bringing to the team?
I always admire this truly about medicine doctors because they're basically expected to know not only how to treat different disease states, but how to diagnose it. And really, the diagnosis is what I feel like is their benefit. A lot of them have knowledge about the treatment piece, but that's where I think clinical pharmacy becomes like it's a partnership. If they're there to diagnose and to figure out what's going on, then the pharmacist can take it from there when it comes to treatment to determine what's best for that specific patient. So I think that's where the biggest role is for transplant pharmacy is that, yes, they may know general knowledge about different disease states, like about diabetes or different medications. But to think that we spend 4 years just learning about drugs and they spend 4 years learning about all of it, like I think that's a lofty goal that they wouldn't need the support of a drug expert, right? So on my team, we are highly regarded for our knowledge and our ability to navigate different situations. And the other thing that I think is really important about, at least in the centers I've worked at, so on the liver transplant interdisciplinary team, it's surgeon led. That's not the case everywhere. Sometimes it's hepatologist or nephrologist led, depending on where you are. And then we'll have the mid-level practitioners, your nurse practitioners, your PAs. We have the clinical pharmacist. And then there are dietitians, nursing coordinators to help just kind of balance out all of the patient's potential needs, social work, and the list goes on. But the core of that team are the surgeons, advanced practice providers, and the pharmacist. So we and the surgeons rotate on a weekly basis, the nurse practitioners rotate on a weekly basis. The pharmacist is the only continuity from week to week who can really speak to, well, last week we made this decision because this happened, or the patient was having this side effect. And that is so crucial for those patients that have longer courses in the hospital, that you don't just reverse decisions that you made the week prior. We really get to help. We know our patients well because we spend more time with them in a consecutive manner, right?
Yeah.
And so that helps for the overall decision making for the team, in determining what the patient may need in order to become healthy and be able to leave the hospital.
Excuse me. I hope you don't mind if I cut in for a moment.
Hurry up.
Number one, thank you for watching. I hope you're learning something new in this episode. Number two, which is the reason I'm here, is if you don't mind, could you be so kind and like this video or hit the subscribe button?
I mean, I've always subscribed.
By subscribing, you're letting YouTube know that my content is providing you value, and that ultimately helps the channel grow and reach more people who need to hear these conversations. You can also subscribe to the Pharmacy Pathways newsletter to get access to exclusive episode content. Newsletters go out in the same week of the episode. You'll receive a structured summary of each interview, expanded guest bios, and exclusive sneak peeks of future episodes. Subscribe at pharmacypathways.org. Link is in the description. Oh, and one more thing.
Hurry up!
If there's a specific topic or career you'd like to see featured, you can let me know by filling out the audience feedback survey on my website. And if you'd like to be a guest, there's a guest sign-up form on my website as well. Both of those links are in the episode description. Okay, let's get you back to the show. What is it, like you can just give a bullet point list of all the things that your brain is thinking of when you are choosing a medication for a patient, like the labs, the side effects, like your brain now probably makes these decisions, like this is like a little calculator within minutes to seconds. But so like what all is computing in your brain that that's going through when you're picking a medication?
Yeah. It's funny you ask this because I was just asked to basically be evaluated on how I work up a patient so that we can try to standardize and streamline it. But there's just so many things that, to your point, I feel like I'm thinking about without even having to do a deep dive. So as soon as I'm looking at my patient's medication list, I'm asking are they on all the appropriate anti-rejection medications? Are they on the appropriate anti-infection medications? Are they on all of our standard prophylaxis? And if they're not, why not? What's the reason? And then I'm going and looking at their labs, and I'm looking to assess their LFTs, their renal function. Is their white blood cell count and platelet count stable? Or because that's often a medication-induced side effect if they're dropping or rising. If not, it could be infection related. And so then I'm jumping and I'm looking, is their hemoglobin stable? Are we having bleeding issues? And then I jump and look at any new cultures that popped up. What antibiotics are they on? Are those doses appropriate? And it's all happening so quickly. And it's honestly a beautiful thing to see it now. And it takes me a few minutes to work up a patient and be ready to discuss them on rounds. And that was not what fourth year Alicia was doing. You put in the hours, you put in the grueling in-depth chart review so that you can get to this point. So for all of the current pharmacy students or future pharmacy students, it gets better, please. I promise you it will get better the more comfortable and the more you do it. But then so one of the big things we're doing as a transplant pharmacist is we're dosing a narrow therapeutic index drug. That's the Prograf or tacrolimus I mentioned before. So we're trying to keep it in a certain drug concentration target that's going to minimize side effects, but also prevent rejection. And so I'm spending time assessing their current dose, what their level is, and all the factors that can go into why that may be low or high, and then coming up with a recommendation to change it all in split seconds. So there's a lot that goes into it. I think you kind of get into a groove and it's kind of become second nature. And I always tell my students it's more of an art than a science, but I feel like you get the hang of it, and it's one of my favorite parts of the job, even though it's not really. You're just kind of you get a touch to it. Does that make sense?
Yeah, it's like once you know how to cook a meal really well and you don't need to cook, it's like
exactly.
when people tell you like just a dash, you're like, well, what is a dash? I've never made this before. But like you are just when you're an expert at something, you just get a feeling of like,
Yeah.
let's go up like 2 milligrams and that will do it. And yeah. I remember that. I remember having to come in and check the drug levels and I think you said NTI, so narrow
Mhm.
therapeutic index. For those who are unfamiliar, there is a very narrow range of medication that can be in their blood at one time. If it goes past the upper end, then we're running the risk of toxicity. If it's too low, then we don't have enough medication that is therapeutic enough to do what we need it to do. And you have days to make sure it gets to where it needs to be. And can they get discharged before it gets to that range?
Usually, no. You have to be very aggressive, and if they're not, are certain circumstances, but ideally, you want all of that to be teed up and stable before they're able to be discharged.
I remember this weighed in a lot with my pharmacist, and the thing she thought about was their financial circumstance when they left the
Mhm.
hospital, right?
Very good point, and it comes up more often than you would think. So, as I mentioned, social workers are a part of the transplant team in the evaluation process. Financial also does an evaluation, but that doesn't necessarily mean the meds will be affordable for your patients post-transplant. So, it's something that I dealt with a lot as a resident training because we were definitely serving a lower socioeconomic group of patients than I feel like I serve in my current role. There's definitely a good mix, but you see a lot more affluent patients as well. So you just really never know, and you never want to assume that patients will be able to afford expensive therapies. So more than anyone else on that interdisciplinary team, the transplant pharmacist is always thinking about, is this something that my patient's going to be able to continue when they get discharged? Because ultimately, if they say the med is too expensive, I'm not going to take it, then there's no point in us trying to transition them to it. So we are fortunate to be able to have altruistic donors that often can help cover the cost of medications for our transplant patients. But if not, regardless, I'm always trying to be diligent about minimizing cost, reducing any unnecessary medications, because this is my personal soapbox that polypharmacy is not something that I want to contribute to. And then having alternative options if a patient is not able to be placed on the more expensive, newer therapy that a provider might want to utilize.
And that team just put in a lot of work and resources to give them that new organ. Somebody sacrificed that organ. So that is a huge piece of what goes into the medication selection process. So I want you to put like all of the things that we talked about together, giving like what your day to day looks like. How are you starting your day? What the typical shift looks like, and what time are you walking out, checking up the deuces and saying, I did a good job today. It's time to go home.
One of the things about transplant, you're waiting on those tacrolimus levels, like I mentioned, and those usually the lab takes a little longer. So most of us, myself included, get there between 8 and 9 a.m., depending on the service, usually more of like a 30-minute window if you're at the front or the back of that. And technically we finish at 3:30. So there are some days where that's the time that we dip and we sign out and we keep pushing. But oftentimes we're all staying later, I would say between 4 p.m. to work on projects, any policy updates that we didn't have time for during the day, and also just to prepare for the next day. I think my day to day, so getting there around 8:30, I spend the first hour and a half of my day going through my charts, looking up any new things that have occurred overnight, new infections, changes in their labs, so that I know what medication changes I want to make on rounds when we discuss it as a team. And oftentimes I'm putting in those orders as I'm going through it. And then I save questions that I know are more like the big questions. That's what I'm saving for rounds so that we can discuss it as a group. But as we were talking about earlier, like your opinion is highly regarded. So a lot of no one's ever pushing back on my dosing in terms of, well, I would have done this instead of that. So there's a lot of things that I have autonomy to do in the morning as I see fit. And then we'll discuss big changes or anything that we need to make a decision as a team when we're all together. Rounds can take anywhere between an hour to 2 hours or longer, depending on how much time the surgeon has. It's unfortunate they're constantly being pulled every direction back into the OR. So you never know how much time you're going to get with them. And we do a good job of trying to hit the highlights and what are the major things we need their input on so that we can keep functioning to get people admitted when they need to or discharged when they need to. Outside of that, I have meetings like everybody else. We have 2 residents in my program, and I had 2 residents. I was one of 2 residents when I was a trainee, so they're constantly on rotation with somebody. So you either have topic discussions as a team or for your particular learner, We take several students a year, and then I'm involved in a lot of different administrative subcommittees and teams for the liver transplant program. So whether that's quality and we're reviewing protocols or reviewing cases of graft loss or fatalities as a group, but basically the committee that determines who will be listed for transplant. I attend that on a weekly basis for both deceased donor and living donor liver transplant, so that we can
Is that one meeting a week?
two separate meetings.
Two separate. So one for the deceased and one for the living?
Yes.
Okay.
So those meetings to get patients listed and closer to transplant, and then obviously discharges. So if I have a liver discharge can take 30 minutes, best case, I would say an hour, depending on the patient's health literacy and comfort with managing medications. So those can stack up, which is why we were very fortunate enough to be able to have that transitions of care pharmacist join the team. So, but I really get a lot of satisfaction out of that piece. So occasionally I'll save one for myself to do if I have the time in my afternoon, but that's typically my day to day.
Okay. So you guys have a transitions of care pharmacist specifically for transplant medication discharges. That's major. I know that that is offloading a lot of work and time.
We train students to do it. There's no reason we can't train an acute care pharmacist to do it. And then they also get to specialize in become more confident in this subspecialty of clinical pharmacy. So it has been a game changer. It frees up a lot of time.
So how many patients are you working up on an average morning?
Yeah, usually my patient load is anywhere between 20 and 35, which is, I'm not saying it's right. I'm just saying what it is.
You answered the question I asked. Excuse me. Hold on. How many livers are there? You said between 25 to 30. And then this is rotating every 3 to 7 days.
What the pharmacy model is that we'll stay in, so either ICU, acute care, post acute care, like rehab or skilled nursing facility. We'll stay in that position for a month. So there is some continuity from week to week, but there's definitely a lot of movement. Patients leave the ICU, patients come to the floor, patients get discharged. So there's a lot of fluidity with it, but I do feel like I get the same general group of patients for about a month at a time.
So you are getting notified once there is a patient in the emergency room, for example, who looks like they're going to need a transplant.
I have not followed pre-transplant. We're only following post-transplant, but let's say the time of transplant, they'll be in the ICU or get admitted shortly before, and then they'll stay there until their needs are no longer critical, right? And then they move to the floor, which is more stable, and we're trying to just prepare you to be able to go home. So determining your blood sugar needs, medication acquisition needs, do you need rehabilitation? So do you have to go get stronger at a separate facility? All of those things we're trying to optimize so that we can get the patient safely home. So that would be the focus in the floor area. And then in post acute care, which is usually a rehab, SNF, or long term acute care facility, it's the same goals, but potentially a slower pace. But the work does vary between those three phases of care, just depending on how sick they are, everyone's complex needs, and then being able to get the meds here and ready for teaching. But it's a lot. I'm not even going front. It's a lot.
You said I work up my patients. I get in at 8 and work up my patients as if you had like 10 or 12.
I would be so, so happy. But yeah, it's
Okay. This is why you have to compute the decisions within minutes, because even if you're, 5 minutes alone per patient is now easily adding up to your workup time.
definitely.
Wow. Okay. See, is that typical for inpatient setting?
I'm going to say no. I think that our liver program is very aggressive. They're big on outreach. They're big on basically transplanting patients that nobody else said yes to. So we have a very large number of patients that we're caring for, but most centers are not transplanting at this rate. We're on track to be number one or number two in the country in terms of volume. So no, it's not normal, but at any point in time, tides can shift and you may have an influx of patients or an influx of transplants. It's so variable. You really just never know.
Okay. So can you give the average watcher that just might have almost wanted to shut off the interview because they're like, absolutely not. Can you give them a more realistic average number that they might see in the hospital setting and then also maybe the clinic setting?
Yes, I think on average, a better pharmacy ratio would be between 10 to 20 per transplant pharmacist managing those patients. In the clinic setting, I feel like it really depends on the role, but I think if you are more of like a med history review and you're doing med recs, that can be more grueling. I feel like when I was a resident, I was seeing maybe 15 to 20 patients in a clinic, which would be just that morning time block. As a fourth year student, when I was in that outpatient clinic rotation, we were doing our own like review, our own meeting with the patients before the doctors would go in and see them. So that would take longer, like closer to an hour. So it varies. I would say anywhere between 8 to 10 if you're having more in depth pharmacy meetings, or 10 to 20 if it's more of a quick pharmacist check in prior to seeing the other disciplines.
I guess you could speak more specifically to the ones you're more familiar with. Like, what is the average number of medications people are going home with that they never were on before?
Yeah, great question. For liver, thinking through like my standard med list for somebody, the default is 8 to 10. Typically have 3 anti-rejection medications, 3 anti-infection medications, and then you're on supplements to help support your body as it's adjusting to these new medications. Liver is usually between 8 to 10. Kidney would be similar. Those lung and heart transplants are where you really see that number go up. It's anywhere between like 10 to 15.
Is this what they are going to remain on for the rest of their life?
The medicines can wean off. I would say usually that quantity is for at least 3 months or so. And then things start to kill off because you've completed prophylaxis, for example, or your steroid dose is down and you're not having any issues with GI side effects. So then maybe you don't need the acid suppressant. So it varies patient to patient, but it's not for life. I always tell my patients that I know it's overwhelming right now and they're losing it a little bit when they see me pull out all those bottles, but it gets better and you're not going to be on all of these medications forever. For life, I would say typically 2 to 3.
Okay. Wow. That's
Mhm.
promising.
Yes, it weans down significantly during that first year, you'll see a big drop off in the number that's needed.
Okay. So the inpatient pharmacist is responsible for doing the heavy lifting of making sure the patient really understands what each medication is for, why it's important, what can happen if they don't take it. I feel like this, out of all my rotations, was the most thorough counseling ever because it literally is life or death. So this is good to know. You're doing a lot of the heavy lifting in the clinical, the inpatient setting, and then outpatient pharmacists at the organ transplant clinics. What does their, routine check-in conversation look like? How are they assisting with the medication and deprescribing plan?
Yeah, great question. So I think those first visits are really touch base to make sure that the patient is properly filling their pill box. They still understand how things are supposed to be taken and they're doing that appropriately. I think the beauty of that outpatient transplant pharmacist is that they can help manage side effects that maybe didn't occur while they were in the hospital still, but now the patient's complaining of X, Y, and Z. And so there's still another resource on the outpatient side to help tailor the specific regimen to help minimize that or mitigate it altogether. Because to your point earlier, if they don't take the medications because they think it's causing a particular side effect, that could be life threatening. So we have to be very diligent about making those modifications, making sure that it's still something that the patient can be compliant with. They're also helping as we meet those benchmarks push transplant. So let's say 3 months, 6 months, certain medications are your prophylaxis period may have been completed. They're there to help make adjustments at that time. A key example, azole antifungals. It's a class of medication that we normally will send patients home on. That typically prophylaxis period is 3 months. Well, that drug has a known interaction with our go-to drug, tacrolimus. So you expect the levels to be higher while they're on that therapy, but when they stop it, that means that the levels can decrease significantly on that same dose that the patient was previously steady on. So a lot of times you may see a patient come in with rejection shortly after that 3-month period if RAF was not appropriately titrated in the outpatient setting. So their outpatient pharmacy is very critical for being able to intercept and intervene and prevent those readmissions to reduce the number of patients that inpatient is looking at, because there are certainly pharmacist interventions that can be made, both big and small, to help minimize admissions.
Who is handling rejections? Are they coming? I remember seeing patients coming back because organs were being rejected by that person's body. And I know that there are things that my pharmacist was looking at to even predict how well that person would receive that transplant, if you want to talk about that a little bit. But at what point are you responsible for patients that unfortunately are back in your on your floor after you were discharged a couple months ago?
Yes. So as you mentioned, there's certain immunological factors that are important to look at for both the donor and the recipient to determine how high risk they are basically for rejection. So if you are HLA compatible, or if you had a positive cross match between the B and the T cells, or both between that donor and recipient, that's just a sign that your immune system is potentially going to be very active against that donor. So none of these things preclude you from getting a transplant, but it does help tailor the immunosuppression plan, both at the time of transplant and that initial hospital stay, and long term. So if you are what we would call highly immunogenic, that may mean you're on higher doses and have a higher neurotherapeutic index or be on them for a longer period of time just to mitigate the risk of rejection than someone who has a very quiet immune system, not very reactive, who you typically expect to be like your older patients, that do not require as much immunosuppression. So I have a mix of freshly transplanted as well as readmissions for any reason. So if you are presenting with rejection, it's the same group of people who are seeing you. We're managing if you need like a IV therapy, so either steroids or something stronger to target those B and T cells that are likely very reactive at that time. And then also making sure that we optimize maintenance immunosuppression again before that patient discharges so that we can prevent the rejection from causing long-term damage. So it's something that I am dealing with on a daily basis, as well as all my colleagues. You typically will present back to that same transplant center and say transplant team that perform the operation.
The human body is so amazing. It will literally say, "This is not my kidney. Get it out of here." And it will literally start attacking the organ. I just thought that was so fascinating. What are some other differences between which environment will be best for them? What should they be considering?
I think that inpatient is more standard hospital pharmacy. So you're thinking about shift work. I'd say clinical pharmacists are usually on day shift. There are maybe a couple on the evening shift, a couple at night shift, but transplant specifically, that's normally a day shift role. And you're working Monday to Friday. But in my experience and all other hospitals that I'm familiar with, there is some sort of rotating weekend responsibility. So currently I work probably it's, I probably averages out to be every 6 weeks, but there are times that it's more frequent and I'm working every fourth or every third. And there are times that I have 2 months where I'm not working a weekend. The schedule varies, but knowing that that's weekend commitment is a part of the expected job role, that's something to definitely take into consideration. On the outpatient side, I think it's a much more standard Monday to Friday, no weekends, no holidays type of role. But I feel like those pharmacists are often working longer days potentially because they have notes to write after those clinic visits, which depending on the pace of the clinic, you may not be able to complete in real time. Projects that you're completing, depending on the duration of your clinic that day, you may not have a lot of admin time in the afternoon. So it may be a longer day. And that's what I saw when I was on rotation with that outpatient transplant pharmacist. She really did a lot of her work came home with her, but it's a balancing act. You have those protected weekends and holidays, or if you choose to use that time to work on more administrative or projects, that's your choice. But it's not as regimented of a day in the sense that the shift ends at 3:30 and you're signed out of your patient. So any time you choose to stay here is really your own choice to get ahead or work on things. So that's definitely something to keep in mind.
Yeah.
I think originally would have loved to do outpatient. And then I kind of fell in love with inpatient as I was going through training. So fortunate enough that I was able to see the beauty in both.
Is there any difference in salary?
Not that I've seen. I think if anything, it really is going to vary by institution before it varies by inpatient, outpatient. The role is different, but I think the role of a transplant pharmacist is so critical that I have not seen a difference in salary depending on the practice setting.
That's awesome. And how many patients? Well, I guess it's hard to say how many patients the pharmacist has. They have a clinic running. So what's the average amount of, I guess, appointments that they might have in a day?
I think if you are conducting your own like clinic visit, that could be anywhere between 8 to 10. But if it's more of like a pharmacy check-in, medication check-in, and medication review prior to the doctor seeing a patient, that could be more frequent, anywhere between 10 to 20 from my experience. But again, those visits are faster. You don't have as much to document. It's just quick check-ins with the patient to figure out what can be discontinued, what may need to be changed, and hear any concerns that the patient shared with the pharmacist that they may not have mentioned to the doctor. So it varies depending on the type of clinic that's set up.
The pharmacist is looking at lab work as well in the clinic setting.
I think definitely yes. And that's more so if you're having like your own pharmacy visit. I think in if you're doing more of that like med rec type of role, it may be a quick check just to see if any of the medications are contributing to the labs, but it's definitely not it would be something that they could bring to the attention of the provider. But if you don't have a scheduled visit where you're sitting down, I don't know how in depth. I would say from my experience, those are so fast paced, you don't really have a ton of time to review the patients in advance. It's really more
Right.
of like a finding out in real time and how can we contribute into the decision making.
Are they with the patient at all, or are they just seeing? Okay, so they are sitting down with the patient, doing a
Yes,
quick review. Okay.
going into the room, but before the provider does, just to make sure that the med list is current. If there's anything that needs to be changed or they have a recommendation to change, they can make that to the provider before they see the patient so that everyone's on the same page about what should be happening that visit. It's not as holistic, I would say, in that type of setting because it's really making sure that you're just reviewing medications. It's a lot faster of a visit, which means it can't be as thorough.
Yeah. Okay. Do they have access to claims information so they can at least see if this patient is adherent on their refills?
Same integration and insurance claim information that we're able to access on the inpatient side that outpatient pharmacists can see.
Okay. Anything else for the differences between inpatient and outpatient that they should know?
I think we covered the big things. Again, the outpatient structure can vary greatly depending on that transplant program, but I think those are asking specific questions about how it's structured, what the pharmacist's role is. All of those things are really important as you're trying to select a program or trying to select a job and knowing what your responsibility will be because it does vary widely, inpatient and outpatient. But just, I think if you have a good understanding of what are all the different things a transplant pharmacist might do for their team, focus your questions for understanding what the expectation is of your particular role.
I do like to explore like where we can go with our expertise, other doors that it can open up for us, because sometimes we don't want to, do the same thing for more than 5, 10, 20 years. Transplant pharmacists, where can they go? Where can they take their expertise? What other doors does this open for you and your professional longevity?
Yeah, great question. I've seen many a transplant pharmacist hang their hat and move on. And just giving you some examples of the roles I've seen just from my personal experience, seen them take. Industry is a big one. That is one of the, I would say, biggest threats to clinical transplant pharmacy in that hospital setting is because of just totally different sort of like work-life balance, salary expectations, those different things that it tends to be an avenue that a lot of transplant pharmacists will take when they um, decide that they're ready to move on from clinical pharmacy. And that's not always as a medical science liaison, which is very popular, I think, role for people who are clinically trained to then take that knowledge and apply it to a resource for doctors. And like you're working for a drug company, but you're trying to help them understand how that drug would be beneficial to their patient population. So that's one option. There's also, I've seen a lot of pharmacists go into research for either companies or research institutes just to translate all of the skills that we've gained in residency training and knowledge about the transplant population to tailor research projects and to develop those plans if that's an interest of someone's. I've also seen, this is a slightly different than what you asked, but because we talked about how broad of knowledge and how holistic transplant pharmacy is, I've seen people take non-transplant jobs after they finish training. Like I know a pharmacist that took an outpatient cardiology role. I know a pharmacist that took an inpatient internal medicine role. You really get such a well-rounded learning experience by having to manage so many different disease states that you can apply it to other clinical settings, or if management is a pursuit, there are definitely been pharmacists that move up in any management role. There are lots of options beyond clinical transplant pharmacy once that's something you're ready to consider.
Well, Alicia, Dr. Scott, is there anything that you would like to share with these aspiring SOT pharmacists?
No matter what type of postgraduate training someone chooses to pursue, whether that's a first year, second year, in any sort of specialty, it is going to be tough. It's meant to challenge you. It's meant to put you in a position where you have to grow and remain receptive to new information, but also feedback about your own performance so that you can continue to become efficient and optimize that. So you have to protect your own mental health during that stage. I think that there's so many different ways people do that, whether it's through hobbies or spending time with their loved ones. I think having a good core of people to rely on is so important no matter what phase you're in. But it also is helpful if maybe you have other co-residents going through similar challenges as you so that you can emotionally lean on one another when things get hard. It's really brutal, but I think on the other side of it, if that's really what you're passionate about, knowing that it's a limited amount of time and that you can get through it because those preceptors saw something in you and your resume spoke to something as well about your capability. So just staying positive, taking the feedback and using it to make you stronger and better and more well-rounded. That has to be the focus instead of the opposite, because that could be detrimental to the future you're hoping for yourself. So that part is definitely something to keep in mind. It's not an easy road, but it's a very rewarding road and a rewarding role that you then get to serve in a patient's life. For me personally, I just got to take care of a loved one as my transplant recipient. And so that was such a full circle moment. I feel like a lot of people want to go into transplant because they know someone who's had a transplant or something like that. And then that moment came for me after the fact. But it really is life-changing, and it's just a joy and a blessing to be able to be part of that journey. Not only someone that you know, but every single patient that you touch. So I hope if it's something you're interested in pursuing, that you feel a spark or a passion and know that it will be a lot of work, but I believe in you and then you can do it.
We have so much more success when we choose a hard path that we're actually passionate about.
Mm-hmm.
So I want them to pick up on that, emphasize on the if you're passionate, because if you are not, it will be very hard to endure. That's anything in life that's challenging, but also it's a big investment, time-wise, energy-wise, financially. So I really hope that they soaked all of that in, and I appreciate your wise words. And that is amazing, the full circle moment. I want to thank you for your time. You shared so much insight. If anyone was coming in here with questions, I think they had a lot of things answered. Thank you so much for everything that you shared, and thank you for all that you do.
Thank you, Dr. Dunlum. Anytime. It was a pleasure to be with you today.
Everyone, we thank you for watching. We hope it blessed you. And with that being said, we want you to stay blessed and stay curious. And we are out.
Bye, y'all.
You just watched an episode of Pharmacy Pathways, a podcast created to help current and future pharmacists find their happy place in life. I'm your host, DomThePharmacist, and I interview different pharmacists from various careers, asking them the questions you'll likely need answered in order to know if that particular role aligns with your interests, passions, skill sets, and talents. If there's a specific topic or career you'd like to see featured, you can let me know by filling out the audience feedback survey on my website. And if you'd like to be a guest, there's a guest sign-up form on my website as well. Both of those links are in the episode description. Thank you for watching. Stay blessed and stay curious. I'm out.